Respiratory viruses. Case: a 3-year-old child presented with low-grade fever, dry cough, difficult to breathe for 3 days. So it seems acute history. A 4-year-old brother also had the similar condition. The immunization is up to date and no any associated comorbidities. Family history also normal. Think, what are your differential diagnoses? What investigations do you request to arrive at a provisional diagnosis? What specific tests do you order to arrive at a definitive diagnosis? Do you prescribe antibiotics? Antivirals. Bit of definitions related to provisional diagnosis. Influenza-like illness, case definition WHO, an acute respiratory infection with measured fever more than or equal 38 degrees of centigrade and cough with onset within the last 10 days. In contrast, severe acute respiratory infection, it's a SARI case definition, is an acute respiratory infection with history of fever or measured fever and cough with onset within the last 10 days and requires hospitalization. What do you think about this case? It seems no need of hospitalization. But what is the provisional diagnosis? Right. Viral infection of the respiratory tract. So this history implies acute history, low-grade fever, dry cough with difficult to breathe. And there is a family history as well. So it implies an acute onset, contagious nature of disease because her 4-year-old brother also had the similar condition. So what are your differential diagnoses? So it more towards acute viral respiratory tract infection. So what investigation? So when we go through, you will, what specific test you will understand. Most important thing is, do we need to do antibiotics, antivirals? Think. So viral respiratory tract infections, viruses. As you know, there are several viruses. Orthomyxoviridae, paramyxoviridae. So influenza virus, parainfluenza virus. Then respiratory syncytial virus. Then rhino, corona, adeno, human metapneumovirus, and Boga virus. So viruses associated with respiratory infections, syndrome commonly associated with coryza or rhinitis, like just common coryza, rhinovirus, coronavirus, influenza. Any of these viruses can develop coryza. Influenza, croup, parainfluenza, main, but others also possible. And bronchiolitis is often RSV, respiratory syncytial virus, but others also parainfluenza is possible. Bronchopneumonia, any of viruses, but commonly influenza virus, RSV, adeno. Any group of virus, any what I mentioned earlier, can be a cause for bronchopneumonia. All over pneumonia. About influenza virus. It's RNA virus. It's envelope virus with hemagglutinin, HA, and neuraminidase NA spikes, denotes by HA and NA spikes. Based on these combinations, we classify them as H1N1, H1N5, H3N5, likewise. There are 3 types. Type A undergo, that is influenza type A, type B, type C. Often influenza type A undergoes antigenic shift and drift. You will understand. B only antigenic drift. Often C is stable. It means C doesn't make more clinical varieties. This antigenic shift and drift are mutations. Antigenic shift because it's a segmented RNA. 8 segments are there in RNA. So these segments, since 8 segments are there, they can mix up with. So it turns with part of this segment is goes, it called shifting. Antigenic shift is an abrupt change of HA, hemagglutinin, due to genetic resortment results in a pandemic. Often it leads to pandemic. But in antigenic drift, it's a gradual change in HA and NA proteins results in epidemic. It is drift is often point mutations like, but shift is a larger variety. It leads to novel onset of HN combinations leading pandemic, intercontinental spread, like nowadays corona. Influenza also in history implies there are a lot of pandemics and there are epidemics. So what is reassortment? Reassortment. It's a reassortment. So usually peak is the amplifying host or incubator life. So imagine one person got a human, one way of H1 in one line. We say other human got H1 in three. But these are coming more often from peak. So usually what is happening is this H1 entry comes and avian one, another one, H1, we'll say H2N1. So when here they comes and mix and forms H1N1. I said H1 entry, H2N1. So ultimately they mix this incubating, amplifying nose. So usually these are originated or arise from avian, so birds. So they can develop any type, any kind of. Similarly, one human can develop any kind of. Once they come and enter into the pig or swine pig can develop the similar conditions, but later due to this reassortment, antigenic shifting, they can develop H1N1 or any variety. So epidemic, bit of definition. I said earlier, epidemics of influenza A and B rise due to minor antigenic drift, whereas pandemic, it's a major change. So there are three antigenic shifts occurred in 20th century. H1N1 is Spanish influenza or Spanish flu, huge number of deaths, Asian flu, 1957, H2N2, H3N2 Hong Kong flu, and H1N1 re-emergence, but luckily no pandemic. Influenza viral replication as same as other RNA viral replication. Usually supporting these intracellular, these are parasites, coated vesicles, then they within the ribosomes, they form protein materials and amplification of this mRNA synthesis lead to RNA replication. Then membrane proteins, all the translation leads to mRNA synthesis, the Golgi apparatus, synthesis and glycosylation of envelope proteins. Then ultimately these form nucleus, surround with the nuclear membrane proteins, leads to body. So the glycosylation leads to insertion of envelope protein into plasma membrane, completion of glycosylation of envelope proteins and lead to progeny. So body. Avian influenza, what I said, H5N1, H2N9, H9N2, there are clinical presentation in every viral almost same symptoms, usually much more severe than the common cold. Incubation period 1 to 2 days, fever, chills, muscle aches, pain, sweating, dry cough, nasal congestion, sore throat, headache, malaise, and fatigue. Some or all of these symptoms may be present, but these are more towards acute upper respiratory infection. But if it goes for lower respiratory infection, including pneumonia, symptoms vary. So what are the complications? It leads to bacterial pneumonia. So with the presence of virus in the respiratory tract, which leads to defect in the local immunity, innate immunity as well as adaptive immunity. So influenza can damage the lining of the respiratory tract, leading to bacteria establish an infection, especially Streptococcus pneumoniae and Staphylococcus aureus are the common cause. So secondary bacterial infections in viral infected, viral respiratory tract infection. So we often want to think about covering once if patient is having secondary bacterial infection, how do we detect this? So usually about that particular patient, clinical history, and we do what are the investigations? We do full blood count. It gives, we'll say, initially leukopenia, but later on leukocytosis. Neutrophil often normal. Full blood count, total count also often in the normal value, within 4 to 11. Like so, but we do CRP. CRP often maybe around 20, 30. Like if we do procalcitonin, it's often less. If it is genuinely viral, it should be less than 0.5 nanograms per milliliter. But Then we think, do we need to start antibiotics? No. Antivirals, if in the pandemic or suspect in influenza, we can go with oseltamivir or saminivir or faminivir like drug. Otherwise, we don't. But often, unless we go for the specific diagnosis, we can do the nasopharyngeal aspirate or PCR. Nasopharyngeal aspirate go for the polymerase chain reaction or immunofluorescence assay. If we get as influenza, ideally we would have start antivirals. But for the empiric basic, we can start antivirals and maybe still we can differentiate is it genuinely acute viral or is it atypical microbes like Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella pneumophila. So best thing is it's go with the macrolide, either clarithromycin or azithromycin or levofloxacin. It's a novel quinolone. So, but uh, ideally in the viral upper respiratory tract infection, no antibiotic is required. It's symptomatic management only. So, but if 2 or 3 days later, if you do another CRP, if you do a procalcitonin, and fever may be not responding. So that's we think is it's a secondary bacterial cause. Secondary pneumonia complicated with bacterial infection. Then we have to think about covering about streptococcus pneumonia and staph aureus. Even we can give coamoxiclav or strep pneumonia, even coamoxiclav will be both. But if it is MRSA, we want to think about vancomycin or linezolid. It depends. So that's the overall management. Laboratory diagnosis, so what I said earlier, it's there. Antigen detection, viral isolation, serum. So always think about what is the specimen, what are the tests? Is it antigen detection? Serology, it's antibody detection, viral isolation, or molecular diagnostic. Here, like bacteriology, cultures are not often done. Cell cultures, tissue cultures done for research purpose, so antiviral development purpose, for the diagnosis purpose, it's not done. Even the electron microscope, it's not done. So usually it's a antigen detection or serology or go for PCR molecular diagnostics. So management, it depends, okay. Other thing is about the prevention, there are vaccines. Southern hemisphere and northern hemisphere vaccines are there in the world. Vaccination means an inactivated trivalent vaccine, usually for A, 1A, H3N2, 1A, H1N1, and 1B strain. That's one we cover it. Maybe 30 to 90% are protective. Usually, it's advised to give debilitated, elderly, and immunocompromised individuals. Also, for the pregnant one, it's inactivated vaccine. There's another vaccine. It's a live attenuated vaccine. It's given as a nebulization or nasal way. So also amantadine prophylaxis or oseltamivir prophylaxis. So what are the other viruses which cause common cold? Rhino, corona, adenoenterovirus. I said earlier, any virus can cause common cold. About rhinovirus, it's a single-stranded RNA virus in the picaноvirus group. It's acid labile. At least 100 of serotypes are there. It's very difficult to develop a drug as well as vaccine. Coronavirus, current problem. It's a single-stranded RNA virus enveloped pleomorphic morphology. You know SARS, severe acute respiratory syndrome virus in 2002. Later nowadays SARS-CoV-2. This is bit about SARS-1. It's there in China. Again, China is the problem. SARS-2. There is no specific characters. Same fever, headache, general malaise, initial mild respiratory symptoms, dry non-productive cough, respiratory distress lead to deaths in 3 to 30% of cases. These are how these bronchopneumonia develop out and healing phase. But for the radiology, it takes 2 to 6 weeks to show the healing. Lab diagnosis, same. Apart from, often we ask blood cultures for bacteria, sputum, gram stain, and culture for bacteria. Then testing for viral respiratory pathogen, not plus AB and RSV. Then legionella and pneumococcal urinary antigen testing also to exclude atypicals and typical to exclude test radiograph. But if we do procalcitonin, it helps to differentiate is it bacterial or viral. Often viral, it's negative. Treatment, no treatment, that is symptomatic treatment only. Paramyx viruses, I think measles forms done earlier. It also can cause measles respiratory infection, mumps not. It's mainly otitis likewise, and ear infection, and also it can be adenitis, like salivary gland infection, but respiratory infection mainly RSV, respiratory syncytial virus, and parainfluenza virus. One piece of single stranded RNA, negative polarity genome. There, parainfluenza virus, there are 5 serotypes: 1, 2, 3, 4, and 4B. Like clinical manifestation almost same. Laboratory diagnosis: specimen, always nasopharyngeal aspirate or nasopharyngeal swab. Antigen detection, serology, viral isolation, molecular diagnostic, management, only symptoms. So we can give alleviation of bronchospasms, secretion reduction, pain management, analgesics, and antipyretics for fever management. No vaccine is available. RSV is a common etiology and it causes bronchiolitis and pneumonia in infants. What is like syncytial virus, syncytial formation? Fusion protein causes cells to fuse, forming multinucleated giant cells. That's why it's termed syncytial formation. Syncytial. Epidemiology, bit. So nosocomial possibility also there, apart from in our country, there is a temperate country, so it's associated with 2 peaks, associated with 2 monsoon patterns. But in other countries, it may be common in winter periods, like, and it can be a nosocomial pathogen. Nosocomial in the sense hospital-acquired infection. Transmission, all the viruses, including respiratory droplets and even influenza aerosol, COVID also aerosol. So there are some risk groups for fatal RSV infections: infants with congenital heart disease, underlying pulmonary diseases, immunocompromised individuals, nephrotic, same as immunocompromised, and cystic fibrosis. Cystic fibrosis, it's not common in our country. Clinical manifestations almost same, but it gives bronchiolitis like complications, apnea. So one possible laboratory diagnosis, what I said, immunofluorescence we can do, and if you do immunohistochemistry with the tissue biopsy, lung biopsy, alveolar, we can see multinuclear giant cells, so syncytial formation, but it's rarely done. Treatment, symptomatic, and aerosol ribavirin is civil infants, it's given, and vaccines, it's there, but it's not properly. Laboratory diagnosis, same. Treatment and prevention, same. No vaccine. Adenovirus properties are there. It's a DNA virus. Adenovirus, not only respiratory tract infection, it causes multiple, like gastroenteritis, CNS infection, cystitis, likewise, there are a lot. So adenovirus cause disease that in no respiratory, what I said. Here we are mainly discussing about the respiratory. Clinical syndromes, there are multiple, what I said. Laryngitis to meningitis. So there are adenoviral types, but it's not need to recall, just get the idea how they differ. Meningitis 3 to 7 line. Pharyngoconjunctival fever, acute respiratory distress in mild recruits. There are some disease entities. Infection of the eye. Acute follicular conjunctivitis, epidemic keratoconjunctivitis. Acute follicular conjunctivitis, which is part of syndrome of pharyngoconjunctival fever. Epidemic keratoconjunctivitis is a distinct difference syndrome. Is characterized by an aggressive conjunctive, aggressive. and pain, photophobia, and lymphadenopathy, followed by development of superficial puncture keratitis. Keratitis. It's another entity, acute hemorrhagic cystitis, and infection in the gut. In the immunocompromised, it causes SCID, severe combined. In the immunocompromised patient with severe combined immunodeficiency, they are more prone to get pneumonia and hepatitis. Also, AIDS1, bone marrow transplant recipients, the DNA virus, which adenovirus have been demonstrated 8% of bone marrow transplant recipients. Laboratory diagnosis same. Treatment, vaccine available in adult respiratory disease syndrome, but it's not done in our countries. Human metapneumovirus, a novel emerging virus detected in Netherlands. Now it is exists in Sri Lanka as well. It's a paramyxoviridae. It's a single-stranded RNA virus. It goes same as other spectrum is clinical spectrum is almost same. About the human Boca virus, it's another virus. It's a new emerged virus. Clinical spectrum same, but exists in Sri Lanka, but less. Bit of acute respiratory infection in children in Sri Lanka. This study done by myself on 1.5 years, checking 1 month to 5 years of age, 1 to 60 month of age, patients doing nasopharyngeal aspirates on acute respiratory infections in inward patients. So you can see common etiology is RSV, followed with parainfluenza viral 1, 2, but human metapneumovirus case also associated with RSV peak. So RSV peak in rainy season in here, Anuradhapura. In dry zone, wet zone, it was found around June to July. It's throughout the year, it's there. That's other thing. So thank you. Think about this.